Now, what's interesting about the AMH, I will say, is that while it can tell us egg reserve, high and low values, higher the number, higher the egg reserve, lower the number, lower the egg reserve, it does not tell you your ability to naturally get pregnant.
Welcome back. I'm Dr. Angel, here with my apparently fertile brother, Raman, and today we're joined by Dr. Rhea Chattopadhyay, a reproductive endocrinologist and IVF specialist. We've had a lot of questions pile up over the course of this show about the actual science behind what Ashley and Raman went through on their journey to becoming platonic co-parents. So today we're going to get into all of it. IVF gets thrown around as a catch-all term, but most people, including a lot of my patients, don't actually know what it involves or what the odds really look like. As a pediatrician, I sit at the end of this process, which means I see the outcomes, I see the baby, but rarely do I ever get to dig into the science behind how we get there. Today, Dr. Rhea is going to change that. So grateful to have you here, Rhea. Thanks for joining us. And let us not forget our other very special guest, your baby. Thank you for being here, even though you have a newborn at home that you are also trying to take care of.
The youngest podcaster ever.
Yeah.
That's right. That's right. Yeah. Thank you so much. I'm excited to join you guys and chat more about the world of fertility and IVF. So thank you.
So I'm probably not the first person to wonder exactly what an endocrinologist is. So you want to start us right there and get into kind of your background and what exactly you do?
Sure. Yeah. So I'm a reproductive endocrinologist, and fertility specialist is like the technical term. The shorthand of that is REI. And what we are is we're infertility specialists, but we specialize in a spectrum of disease processes, including endocrine processes, things that we don't see as often as well. But basically to become an REI, you go through 4 years of, undergrad school, 4 years of medical school, 4 years of OBGYN residency, which is a big part of it. And then you choose to subspecialize. And so I subspecialized in REI, reproductive endocrinology and fertility, and that's another 3 years on top of it.
So you've been in school for 15 years.
Yeah,
is my math right?
it's been quite a journey. Yeah, you add that up, but yeah, it's been quite a journey. It's been quite a journey to get here, for sure.
So we're so excited to have your expertise so that we can get some of these questions answered. So Raman and Ashley came together as platonic co-parents because Ashley froze her eggs 10 years ago, just catching up some of our listening and viewing audience who may be new to this story. And then Ashley wanted or asked if Raman would be interested in being a platonic co-parent with her. And so then Raman provided the sperm that met up with her 34-year-old eggs. And now the baby is in her belly. And we are wondering, do you see a lot of clients like that? And if not, what do most of your clients look like? What are they looking for? And what kind of guidance do you give them?
Yeah, so I would say, Raman's specific path is a little bit more unique. We don't see that as often. Now, will that change? The world of REI is so new still. The oldest IVF baby, little factoid, is Louise Brown, and she is about 47 or 48 years old now. So it's still a really new field. And so maybe Raman's situation will become more common, and we will start to see more of these platonic couples come to be as time progresses. But what I will say is my most common patient is usually a heterosexual couple who present having had years of trying to conceive and get pregnant on their own. We recommend to come and see one of us, usually within a year, after a year of trying, especially if they're less than 35 years old. And if they're more than 35, after 6 months of trying. But typically my patients have been trying for many years, not maybe aware of these recommendations. And that's when they present to me, trying to figure out why they have had difficulty trying to conceive, and looking for options.
What happens next? Like, do you start with some testing and then what do you offer?
Yeah. And why is the IVF process like what I'm not saying better, but why is it the next stage that could help a pregnancy occur where natural cannot?
Sure. So to answer like Angel's question first about like what initial testing we do. So, we try to figure out if there's anything we can solve pretty easily, for our patients. So there is a lot of testing that we do to see like why is it that they're not getting pregnant? Is it something that's fixable and that if they, we fix it, they can keep trying and get pregnant naturally and avoid the stress as we'll find out about IVF. And so that's always our first goal. We don't want to put someone through IVF if they already have a pre-existing, thyroid condition, if they're uncontrolled diabetic, if they have chronic hypertension that's not being treated, if they're, struggling with lifestyle modifications that they need to make, if there's a tube that needs to come out. There's a lot of different aspects of trying to assess the fertility patient first before jumping, straight to the big gun, which is IVF. So part of the workup includes, hormone testing, so we're going to be looking at their, like I mentioned, their thyroid. We're going to be maybe checking their prolactin if it's indicated, if they're not getting regular menses. We're sussing out the patient. We're trying to figure out what is it about her natural body and biology and her partners, for that record. We're seeing both of them together that's hindering their ability to conceive naturally. Part of that also entails doing a test called the HSG, a hysterosalpingogram. You may have heard of this. It's where we inject dye into the uterus and the dye spills out the tubes and we get these beautiful images and we can see and check the patency of the tubes and see if they're open or if they're blocked, where are they blocked? What is this doing? And so there's a lot of other different tubal pathology that we suss out as well. So we typically get hormones in the beginning. We get the HSG. We also get a semen analysis. And the big one that I haven't yet mentioned is the AMH. So that's the anti-Müllerian hormone level. So the AMH is a big one in the world of fertility. You'll hear AMH a lot on any fertility blog, any fertility talk. And that's a hormone that's produced by your ovaries that tells us what your overall egg reserve looks like. So it's an ability for us with just a simple blood draw without having looked at you, done a formal ultrasound or anything like that. It's our ability to actually just see, what the egg count generally looks like. Does someone have a high egg reserve? Does someone have a low egg reserve? And it helps us also guide, based on the level of the AMH about like what are our next steps? Like how aggressive do we need to be? So the AMH is another important factor. Now, what's interesting about the AMH, I will say, is that while it can tell us egg reserve, high and low values, higher the number, higher the egg reserve, lower the number, lower the egg reserve, it does not tell you your ability to naturally get pregnant. So that's very important. So sometimes patients will come in to the office having already looked at their labs, because that's how my office is set up. We have labs drawn ahead of time before they come and see me. And they'll be like super bummed that they may have like a lower AMH. And then I uplift them in that moment and I say, look, this doesn't necessarily tell us that you can't get pregnant. It's just a value. We take it, amongst everything. High or low doesn't mean that you can't naturally conceive or can't use some type of assisted reproduction to get pregnant. So that's part of the initial workup that we do.
So then if you decide that a couple's next steps are probably IVF, what does that mean? Like just really briefly for a woman or the man, and how do you counsel them on that?
So the process of IVF, in general, is a 3-step process. So there's the stimulation process where a patient will undergo hormonal stimulation, daily injections, to stimulate their ovaries for about 10 to 14 days. So during this time period, it's a very intensive time period. This is probably the most intensive time period for a patient undergoing IVF, is this stimulation time period, because they're giving frequent injections. They're typically given in the belly, and they're coming in really frequently to see their REI physician or ultrasonographer who will be scanning them and assessing how they're responding to the medication. So they're usually coming in every 2 to 3 days, sometimes towards the end of their cycle daily, because we're trying to figure out the optimal time that their ovaries are ready for the next step. So 10 to 14 days of stimulation. Yeah.
So the ultrasonographer can see the eggs at this point? Like what are you looking at on ultrasound during the stimulation period?
Yeah, so we're looking at something called a follicle. So these are tiny fluid-filled sacs, on the ovary. that appear. And those are your follicles. So each fluid-filled sac houses a tiny, tiny microscopic egg that is not visualized to the naked eye. We cannot see that on ultrasound. But we can see is the follicle. And the follicle size is directly related to how mature the follicle is. So that's what we're actually physically measuring. So, when the patient comes in, they're scanning and they're measuring in multidimensionally each follicle to see what the average size is, and based on the size and measurement, making assessments about when they should come back and what the maturity probably looks like for that individual.
And just so I'm clear, when you say stimulating, this is to stimulate the egg retrieval process, correct? Like getting the eggs out?
Right. So step one is to get ready for the egg retrieval. So you can't retrieve eggs that have not been stimulated because they're immature eggs. You need mature eggs for the process of IVF. So that's something that's why patients undergo this intensive stimulation process, is to get mature eggs. So you can't infertilize immature eggs. Okay, so that's why for 2 weeks they're undergoing this intensive stimulation process, taking these hormonal injections, and we're hoping to see on each and every ultrasound as they come in another step towards maturity. And then finally, around day 10, day 12, this is where we start to see on the ultrasound, okay, the follicles have reached this mature size, and we're looking at this whole cohort of follicles. Okay, so and it depends on everyone's individual egg reserve. So that's where the uniqueness of each individual comes into play. But we can usually see several follicles that have reached maturity, and that's when we make a call alongside, getting blood work done. That's another part of it. Where we're measuring estrogen, which is a direct correlation with maturity of the follicles as well. And we make this decision about when the patient should be ready for the retrieval. So they went through this whole process with the goal of getting mature eggs. So that's the goal for the stimulation process.
And that's step one.
That's step one. Correct.
Okay.
Yeah.
Yeah. So in your case, Raman, you got lucky. You didn't have to worry about that at all, because one, it was Ashley doing it, and two, Ashley did it 10 years ago.
Yeah.
And then she froze hers.
Dr. Rhea, is it kind of like the younger you are, the better chances of step one working are, kind of thing?
Correct. Yeah. Age is such a huge factor. We talk about AMH a lot and egg reserve a lot, but age is the number one factor for the egg quality and fertility outcomes. The younger you are, typically the outcomes are that much better. So a 30-year-old will function much higher, in their ability to get pregnant using their own eggs than a 40-year-old, say. So that is very clear that we see.
All right. And so what's step 2 and 3?
Okay, so after we get through, the stimulation process, then we guide the patient on taking a timely injection. That's called the trigger shot. So if you ever watched a movie or a TV show where they're talking about IVF and they're freaking out because they couldn't get the timing correct and they're calling the doctor, we lost the trigger shot. I know there's a couple movies out there that kind of go through this. It's always entertaining to see from a fertility standpoint. But the goal is that should not happen, right? We want everyone to have their trigger shot available and take it at the right time, because really 2 days later is when the patient will be now coming in to do their egg retrieval. So that's the next big step. So the egg retrieval is a process in which we actually extract the egg. So that's done transvaginally, typically using a small needle catheter, and we gently extract the eggs, typically under anesthesia. So the patients are asleep, they're under a deep sedation, they're very comfortable, they're nice and asleep, and then we extract the eggs transvaginally. So typically no big incisions on the abdomen. Sometimes in rare cases, the ovaries are hard to reach transvaginally, and that may, indicate a transabdominal retrieval. Those are much less common. The typical path is the transvaginal retrieval. So that's when we actually get to suction and remove the eggs that we have been stimulating. Okay. And then with that follicular fluid that has now been retrieved, we have embryologists. So we work with a team of embryologists. It's really neat. We're not just just the REI, just the nurse. It's also this whole embryology team that now is going to look at the follicular fluid and identify the eggs that we've now retrieved from the follicles. And this is where we're going to be looking at egg maturity. So As I mentioned, the whole goal of the stimulation is to get as many mature eggs as possible. And that's why like the timing and everything is like so critical. And we're always wavering. Okay, do we go another day? Do we not go another day? And then when we get to the retrieval and we retrieve, we actually get to see, okay, this is how many mature eggs we got. Now, I would love for us to always get 100% mature eggs, but the reality is that, we're going to get maybe 60, 70% mature and maybe 20, 30% immature. I mean, that's just the nature of it. But we would like to get as many mature as possible. And sometimes we get really close to 90%, but it just really depends on the individual, how their stimulation went, how cohesive their stimulation went. And so there's a lot of factors in that, but that's the next step, is the retrieval. So they retrieve the eggs. The embryologist now looks at the flicker fluid, identifies how many mature eggs we have and how many total we have. So that is the next step there.
So, looking back at my experience, which I guess is still going on, um, so I guess like if money and pleasure maybe weren't a factor for a heterosexual couple, why wouldn't everyone choose to get IVF? I asked this because it was so interesting that I get my whole genetic workup done. Ashley got a genetic workup done. They looked at all her eggs. They looked at all my sperm. They kind of one by one went through everything. Then they, like they found the best sperm, the best egg. They combined them. Then they did genetic testing on the embryo. And it's like, wow, I can't picture myself doing this any other way now that I'm choosing like my A student right now. Like they're like, you have an A embryo, a B, a C, a D, and an F student. Which one do you want to pick?
Yeah, it's really interesting that you say that. I think, IVF is a beautiful technology that we have, and I think it is so amazing that we have such an advanced technology to help patients who otherwise would not have been able to get pregnant on their own. Now, as I mentioned, like I've mentioned, step one, to the 10 to 14 days of stimulation, step two, the retrieval, step three is the transfer, setting up for transfer. It's a big process. I mean, this can happen over a period of, 2 to 3 months on average for a patient to get through. If you spontaneously conceive and get pregnant, you conceive that cycle, you're done. You're not taking all these hormone stimulation, all these medications. You're not going through a retrieval. You're not getting set up for the transfer. I mean, IVF is an amazing tool, but those who conceive spontaneously and naturally, I mean, it's very easy for them, right? So that's why, IVF is not for everyone. If someone can get pregnant spontaneously with non-IVF methods, they may prefer that. And again, it's up to the individual how they proceed. For the infertility patients, some patients want to go and jump into IVF right away, and some patients are like, can we try anything but IVF in the beginning? It is a spectrum based on the individual.
So just getting a little deeper into my question, if I didn't have a child through the IVF process, could I still get all that genetic workup done on me and the person I'd be having the kid with?
Yeah, actually, so I think what you're talking about is something called expanded carrier screening. So expanded carrier screening is when we screen you and typically your partner or co-parent for different autosomal recessive conditions. So these are conditions where, if you get screened for, like these panels are big. I mean, the one I work with primarily is like 150 gene panel. There's panels available in other clinics up to 500. It really just depends on what panel that they want to subscribe to. But there's, and these panels are getting bigger and bigger every year because geneticists and technology is getting broader every year. So these panels have been growing from when I started doing this, and so what they're looking for is autosomal recessive conditions. So if you screen positive for something and your partner screens negative, then it's really not an issue because it's a recessive condition. It's not it's very unlikely that you would have an affected child. You really need two genes, one from the father, one from the mother, to have a 25% risk then of transferring that on. Now, if you wanted to be really due diligence before, you met your partner, before you decide to have a child with a partner or co-parent, you guys could both get, your expanded carrier screening done. You can get that panel ordered through your doctor, and see, are you a carrier for anything? Is she a carrier for anything before deciding to have kids? Oftentimes what will happen is people just get pregnant spontaneously in the general population, right? And so they don't know. if they are a carrier for something or not a carrier for something. And oftentimes patients present to the OBGYN already pregnant, so that's the whole other spectrum of it. And in those situations, like there is carrier screening that is offered so that we can see if the patient is at risk for having an affected offspring at all. If they screen positive in these other limited carrier panels, then the husband gets tested, the partner gets tested, the co-parent gets tested, right? And then if he screens positive, then it's a whole genetics consultation discussing the risks of having this transferred, and then a discussion about amnio, genetic testing, to see if they have an affected child or not. So that all can happen in the spontaneous conception route. What's so nice and clean and elegant about IVF is you're doing it all ahead of time, right? So you're doing this ahead of time in the setting of like, we know that so and so is a carrier and their partner is a carrier. And now we have an identified gene and we can actually test the embryos for that gene and only transfer non-affected embryos. So that's a huge part of IVF. It's a very elegant solution, right? It's not messy. It's clean. It's simple, relatively, right? It also brings up other things, but it's a nice solution, for that. But it is available for those who want to try to conceive naturally as well, just in a different way, if that makes sense.
So with PGT, that's after you get your genetic screening. There's a whole another panel of stuff called PGT. Is that how it works?
So expanded carrier screening is like the before, looking at specific genes. So that's how I want, think about them as two different tests. So expanded carrier screening is looking at genes, single genes, recessive genes specifically that you need two to have a risk of transferring something on. Now, testing embryos and the way that we typically test them is called PGT-A. So it's pre-genetic testing for aneuploidy. And so when we're doing PGT-A, that's checking to see chromosomal copy number. Okay, so every individual either has 46XX or 46XY chromosomes. That's a normal complement of chromosomes that we have. And so what PGT-A is looking at is to see, does this embryo have a normal complement of chromosomes? Does it have a 46XX? Is it 46XY? We do get to find out the sex of the embryo, based on these the results. And we also get to see, is the copy number correct? Now we also get to see, is the copy number not correct? So we find out, is this embryo actually a trisomy? Does it have 3 copies of one of the chromosomes instead of 2 copies? Is it a monosomy? Is it missing a whole copy of a chromosome? And as we know, the most common cause of miscarriage, first trimester miscarriages especially, is having an incorrect copy number of chromosomes. And so that's what PGT-A's main aim is to avoid, is to help to, improve our fertility outcomes and reduce our miscarriage risk by transferring a genetically normal embryo, meaning has the correct copy number of embryos. So this is separate to what I was talking about before, which is expanded carrier screening, looking at single genes. Now, if a patient and their partner were found to have some gene that they wanted to investigate because they both were carriers for it, could you do both? Yes, you could do PGT-A and what's called PGT-M. So PGT-M is for monophasic genes, and that's looking at the single genes. So you can test for copy number and the specific gene that both the parents are carriers for. So that's when both can kind of come into play.
And is the only reason to not get all this testing done finances?
You mean the expanded carrier screening or like the PGT?
The PGT, the PGT-M, the PGT-A, the genetic carrier screen, everything. I mean, it sounds like there's almost endless testing you could be doing here, and we all want a healthy baby. So if every test can help aid in that, if there's no limiting factor, should everyone be doing that?
That's a really interesting question. I think every individual feels a little differently about it because, as a physician, as an REI, I offer these tests to my patients. And some, want to know more information. Some are just like you, Raman. They're more information is power. They want to know everything. They want to go in strong, and they just want, whatever in their point of view, whatever is the higher, power that we all, if anyone believes in a higher power, what be, they just want to jump in, without knowing too much, or
Mm-hmm.
and vice versa. Sorry, I kind of crossed myself. But basically, some people really want to know everything and some people don't want to know anything. And I see all of it. Some of my patients are like, whatever is, the high, like the higher power that be, that will happen. I don't want to do any testing, even if I advise them to do some testing, based on their age, based on, their family history. And some people are like, no, I want to know everything. I want to have the, strongest, healthiest baby possible. I want to know everything now that this technology exists. So there's definitely a spectrum, and there's definitely different belief systems and um, different ways of thinking, So while I totally understand your perspective, Robin, I kind of feel that way. I'm like, more knowledge is power, I'm there to really act as a guide to my patients, let them know what is available for them, and then just have them see what they feel most comfortable, pursuing.
Yeah, like when our doctor was telling us that we had like and I might be getting this grading system incorrect. I think there was like triple A, double A, then triple B, then double B, something to that degree. Does the natural process kind of look for that triple A? Does it try to create a triple A more naturally than a triple C or a triple B? Or is that all just kind of like random and we get lucky in this scenario that we have the technology to be like, okay, we got the C, the B, the A, we're taking the A? Or does the natural process usually select for trying to get that best version of human that can be brought on this planet?
Yeah.
Looking most like me as possible is how we're defining best.
Right, right. No, that's a great question. I think we're constantly in the world of IVF and REI and ART, artificial reproductive technology, trying to figure out embryo selection and what makes an embryo, viable. That's the terminology that we use, right? What makes the embryo have the most potential and and be the most viable option? And how does nature naturally select that embryo? I mean, that's a really good question. That's $1 million question. That really is. So what we do in the embryology setting is we look to see what embryo is the most, expanded, most beautiful, most developed, reached its target milestones in a really, um, sorry, reach its target milestones in a very timely fashion. These are all things that we look at, and then in Mother Nature, Mother Nature just does that naturally. So it just kind of selects an embryo. We think it's probably a beautiful embryo because that's what we see on the outside, right? But does that answer your question?
Yeah.
But yeah, the what we do on an embryology standpoint is look at it physically. They're grading the embryos based on a morphological score, looking at how beautiful the embryo is, versus and in Mother Nature it probably has some type of similar mechanism, right? But it's all in vivo, and difficult to actually completely emulate, in the outside world.
I have a question about outcomes. I'm sure parents ask you, like, what are the downsides of IVF? Like, are these kids more likely to have conditions or different conditions than naturally conceived babies? And is more intervention associated with more potential downsides, like if you choose the sperm the way that Raman and Ashley did, is that a higher risk scenario than just not choosing this, not being as specific and not doing a side?
And the fact that it's done in a lab,
Yeah,
right, and not in a human body.
right. And I know there have been a lot of studies on, and some show one thing, some show another in terms of different outcomes, neurodevelopmental outcomes. I think even looking at cancers. And so, what's the bottom line? How do you counsel your patients?
There are risks associated with IVF that we should all be aware about. And the risks that I quote my patients is that there is, risk inherent to the procedure of IVF, so we always talk about that. Undergoing hormonal stimulation, stimulating your ovaries. Some patients with especially high egg reserves may be at risk of something called ovarian hyperstimulation syndrome, which is called OHSS, um, and risk related to the procedure, the retrieval. So those are things I always talk about with my patients. So they should be aware about with that. Now, risks with having the pregnancy and the baby and the outcome, which I think more specifically you asked about. There are some things that we have to be mindful of. Overall IVF is really safe. Overall risks are really low. Overall, plenty of healthy children have been born through IVF, which is, wonderful. But there are some small upticks in risk, such as in pregnancy, small increased risk for preeclampsia in pregnancy, risk of preterm delivery. Having a delivery around 34 weeks, 35 weeks is not altogether so uncommon with an IVF pregnancy. Um, Risk of congenital anomalies is a question I get a lot. Will my baby have some birth defect or something? So in all the studies that we've seen, the overall rates are very low, but there is a small uptick. So if you think about a couple that gets pregnant spontaneously, their risk is not zero. Okay. So the risk of having a congenital anomaly is around 2 to 4%. That's kind of population risk. And with IVF pregnancies, about 2.5 to 4.5%. So, absolute risk is a little bit above, but it's overall still a very low risk. In terms of neurocognitive development, there hasn't been really much seen. There's been a little bit of a mixed data, but more reassuring studies more recently. And so overall, I would say, very positively, thankfully, IVF babies are healthy babies. They do very well. And again, as I mentioned earlier, our oldest baby is Louise Brown, who's now 47, 48 years old. And so she's really like what we have as a marker for what we're seeing for the future of these IVF children. But she so far is a healthy individual. She's been able to have 2 children of her own, I believe spontaneously. I would have to double check that, but I believe spontaneously. So, so I hope that helps kind of answer that a little bit.
Yeah. And does doing the ICSI, the intracytoplasmic sperm injection, does that change anything in terms of outcomes or risks?
So ICSI is interesting. There's 2 main ways to inseminate eggs. So just to kind of give a little background, there's conventional insemination where we just combine the eggs and the sperm naturally, in a petri dish. We let Mother Nature, do the job and let Mother Nature have, its innate powers of sperm selection, whatever eggs fertilize. We see that. So that's a component. And then there's ICSI, which is what you're asking me about, which is intracytoplasmic sperm injection, where we take a singular sperm and inject it into a singular egg. So we're superseding all of Mother Nature. We're the ones selecting the sperm. We're injecting it into an individual egg. We're bypassing, Mother Nature's mechanisms. Okay. And so, yes, there was, some questions about the, safety of this. And to give a little bit more background, ICSI was actually primarily developed for patients with really severe male factors. So these are men who had really poor sperm counts, terrible motility, poor volume, the whole 9 yards, and that's where ICSI really came to play. Now, we use ICSI for a lot of different reasons, even sometimes in patients with non-male factor infertility. But the oldest studies that we have that we're identifying and seeing, were there any, congenital anomalies or concerns, found a small uptick risk in something called hypospadias, male hypospadias. And that's where the penile opening of the male urethra is slightly deviated from the midline. And that was a very slight increased risk. And that was identified in these older studies that really looked at ICSI in the severe male infertility population. So it hasn't really been able to determine and differentiate, is this because of their specific pathology of having very severe male factor infertility, or is it a process of ICSI as a whole? And that still hasn't been teased out. And I do tell my patients about this as well.
And, we've been talking so much about, or we have touched on, age as a factor for women. Is it a factor for men too?
Great question. So men and their age, now we're seeing that it may be a small factor. It's not as big of a factor as female age. I mean, female age unfortunately really takes the cake in the whole thing. I wish it didn't. It is a primary part of infertility and the age-related effects on the egg quality. Sperm, there might be some, maybe, but it's still being teased out. It's not like loud and clear that male age really plays that much of a role. Maybe a little bit, but it's more so the age of the egg.
I'm wondering if you've ever had any ethical concerns about IVF. I sometimes think about I read a study about how a very small percentage of women come back for eggs that they froze in the last 5 to 7 years. And maybe they'll come back later, but this study happened to look at 5 to 7 years later, what percentage of women came back. And it was a small percentage of women came back and for their eggs, and then the rest of those eggs end up getting thrown away because unless you sign them away to science, my understanding is you can't do anything with them. And I'm just wondering, like, could these eggs be used for something else? Would they be beneficial for science or for other people who can't have babies? Or just curious if there's any thought or conversation about those eggs or frozen embryos also in the IVF community.
Yeah, great question. We're in such a nascent period of time, like in such the early stages where patients have started to do egg freezing. I mean, it was experimental up until 2012. So it really is a newer technology. And so you're right. I think I know the study that you're referring to. And that was looking at some patterns more recently. And it even addressed it in the paper that, maybe this is not clear cut, but this is what we see at this time. This is kind of a snapshot of what we see at this time. And I think it's still unfolding, the nature of how these patients are using their eggs. I have patients now presenting to me at the age of 40, 41, 42, having frozen eggs at 32, 33. And they're in different stages of life. They've either found a partner and they're ready to get pregnant and they haven't been able to conceive naturally, and they're wondering if they should use those eggs from the past or try using their own eggs, or they're ready to use those frozen eggs and become single parents by choice. I see that unfolding actually a lot more frequently now. Which is also interesting. And a little bit on the spectrum with the platonic, co-parents. And now we have single parents by choice. And all of that kind of unfolding where they may have, waited to see, did they find a partnership or someone that they could co-parent with? Maybe it didn't happen for them, but now at 40, 41, they're like, this is my time. Like, I'm not wasting any more time. I have these frozen eggs and I want to use them. So I'm interested to see how the studies unfold from there. Because I think we're still in the early stages of figuring out what that all looks like. Now, in regards to like disposition of eggs and tissue and embryos, every patient does sign these forms, these disposition forms about what they would like to do with their eggs or with their embryos prior to storing them. So that's really, really important. And everyone has different beliefs. Everyone falls in a different belief spectrum about what they want to do. Every patient is a little bit different. Some patients are really against saving supernumerary embryos. They really just want to try to have as many concise embryos as possible to meet their family building goals and really, really do not want to have more than what they need. Others may feel looser about that and feel more comfortable having, more embryos than they need, and it's such a spectrum because everyone's individual situation is so different on what they can actually achieve and not achieve. So it really is such a spectrum. Now there is disposition paperwork that they fill out. So yes, you're right. Some of it is, if they, no longer want to pay their storage fees. There's annual storage fees, right, for all of these embryos that are created and they get stored in a safe facility for use in the future. But if they no longer want to pay their storage fees, I mean, yes, potentially one of the options is disposal, which is what you mentioned earlier. Another option is donating to science. So that is an option that's typically written out. Another option is donation to a couple in need, or a person in need. Do they want to donate their embryos, donate their eggs? And I believe those are the main options there, which is disposal, donation to research, donation to a couple, somebody in need, typically.
That's really interesting. So are those options available for people that have frozen embryos only or also frozen eggs?
Yeah, so frozen eggs, you can donate frozen eggs as well. There's, if you wanted to donate it to a person who would actually use them, or if you want to donate to science, I mean, there is the option for that as well.
We have a couple more questions that came up from previous episodes. You might have covered some of this a little bit, but Ashley mentioned when she was on that she had to take birth control as part of her IVF journey. Can you explain why people take birth control?
Yeah. So when a person gets set up to start their cycle, there's different ways that they can get set up. And some patients have, and it all depends. So she was probably around, you said 32, 34 when she was able to freeze her eggs.
34.
34. So, assuming she had a normal egg reserve and so forth, the birth control is usually a means of getting all their eggs cohesively functioning together, working together. We don't like dysynchrony in cycles. So if you start your cycle and you already have some follicles growing ahead of the curve and some lagging behind, that's a really discordant, disparate cycle. We don't like those cycles. We want everything to grow as evenly as possible because, again, we're trying to maximize the potential of the follicles, maximize their maturity and their reproductive potential. So if we have discordant cycles, it's really hard because we have this pool that's lagged behind and this pool that's ahead, and we don't like that. So birth control really helps to synchronize the follicles as they get started, and that's one of the protocols. There's other protocols, but in her protocol, probably that was the main purpose of that.
That answers that question beautifully. Thank you. And then you kind of mentioned initially when you do some of your screening that you're looking for other problems that can affect fertility, other endocrine problems like thyroid problems, but other problems like celiac too. How can you talk just a little bit about how physiologically something like thyroid disease or celiac impacts fertility?
Yeah. So, we right now, hopefully we're all in euthyroid states. Okay. So, your body needs to be, functioning at its biologically, physiologically status. We don't want to be
So
hyperthyroid. Oh, sorry.
no, I was just going to say you in this situation is spelled EU, which kind of means
Yes.
like normal in medical speak. So you're not hyperthyroid, which is too high, or hypothyroid, which is too low, but you need to be euthyroid. You need to have just the right amount.
Correct. Yes. Beautiful. Yes. So, right. So we don't want our body to be out of shapes, as we're trying to conceive. It actually is a hindrance to our ability to conceive. Your body really wants to be in a really nice physiological status so that it can now, get pregnant and undergo this immense physiological changes that happen with pregnancy. So if you're hyperthyroid or hypothyroid, it messes with your menstrual cycle. You can have, menstrual irregularities. You may not be ovulating appropriately. Your menstrual cycles may be completely, um, uh, just out of whack, really, So, making sure that their thyroid function is normal. If they have, let's say Crohn's or some type of, other GI disturbance, you want to make sure that's mitigated and as well controlled as possible to reduce these undue inflammatory states, as much as possible. So yes, we're always trying to treat the patients and make sure that they are functioning to their physiological best because to be pregnant does require having this healthy, hospitable environment, So we're trying to avoid things like you mentioned Raman and his vaping and his and maybe smoking. Those things can increase free radical exposures. And he's not the one getting pregnant, but his sperm, right? It can dramatically affect that. The same with the person who's hosting the pregnancy, right? So we're trying to make everything, be in a really nice steady state.
I have kind of a question that might be a little tangential, but how long, so Ashley had to have the embryo transferred to her. I think she did it after like 2 weeks, something like that. How long can that wait out? Like, how long has it ever gone out? I mean, can you just grow a baby without the human?
Oh, I see what you're asking. Okay, so you're asking about like embryo culture. How long can an embryo be cultured? Is that what you're asking?
Yeah, and kept viable.
That's a really good question. That's actually an ethical question. Yeah. Um,
Yeah, yeah. So we were on that ethics thing. So
yeah, yeah. So, typically internationally speaking, there's like in research protocols, that's where embryos may have been grown out to 10 to 14 days. It's like before the primitive streak. So that's like in the research world internationally, and I think the US also abides by that. In our lab for IVF, like functionally clinically purposes, we grow out till day 7. So, we aim for a day 5 embryo. That's what we want to hit. That's called the blastocyst stage. At least in the clinic that I work at. Every clinic's a little has their own nuances. But with extended blastocyst culture, we've been able to grow them out to day 5, which is our primary target. If they haven't met target by then, we allow them to grow another day, like day 6. And if they haven't met target by then, another day, day 7. Now, do day 6s and day 7s perform as well as day 5s? Day 6s perform similarly, I would say, to day 5s. Day 7s, not as well as day 5 and day 6s, but they still give you a chance, right, of having a baby. So we do try our best to get as many viable embryos as possible for our patients. But yes, in the lab setting, in the research setting, in the research world, I think day 10 to day 14 is kind of the upper limit for growing out embryos in culture. But then for clinical purposes, it's really between day 5 and day 7, typically.
So theoretically, if it was not considered unethical or somebody wanted to do unethical research, they could continue, or what we currently as society deem as unethical, you could continue to grow this in a lab setting and see how far you get.
Yeah, I'm probably not the best person to ask because I'm not doing that active research, but there's probably some limitations in terms of embryo culture and figuring out how to get the embryos to continue to grow past a certain point. But if it was allowed, I'm sure that could be something investigated.
Yeah, interesting. So yeah, you'd have to move it to the next more hospitable environment. So going back to your targets for day 5, 6, and 7, what are the targets you're looking at?
Yeah, it's looking at what Raman kind of alluded to earlier, which is the morphology of the embryos. So that grading scale that he was saying, and it's every lab again is a little bit different. I think they were really working nationally to kind of homogenize how we rate embryos. So, for example, in my lab, 4AA is like the best embryo, but that might be a little slightly different, grading some symbols, that they use for in another lab, for example, but it might be assessing pretty similar quality embryos. But so you're looking at like symmetry of the embryo, expansion of the embryo, you're looking at the inner cell mass, the outer cell mass. You're making sure that there's no degradation of parts, that it's actually hit milestones between fertilization, day 1, day 2, day 3, day 4, day 5, that it's actually crossed the thresholds. So there's different elements that happen along the pathway to become a blastocyst. So you're just looking to make sure that it's passed through that and it's formed what pictorially looks like this beautiful blastocyst embryo. And those that don't look that good obviously get a lower score.
Yeah, all right. Well, with that, how about we move on to our medical breakdown?
Yeah, so I think Dr. Rhea, you mentioned this earlier but I think it's an important part of our overall medical breakdown that in patients having regular unprotected sex for 1 year, and if they were trying to get pregnant and they didn't get pregnant, it's probably time to see a reproductive endocrinologist, an IVF or an infertility specialist. And if they're over age 35 and they're trying to have a baby for 6 months and not conceiving, it's time to see a fertility specialist. Is that correct?
Correct. Yes, definitely. Yeah.
Okay. And the other thing I just want to make sure everyone walks away with is that we're saying IVF, but really we're talking about assisted reproductive technology. And that can mean different things in different situations. Some people have their own eggs. Some people have egg donors. Some people have their own sperm. Some people have sperm donors. You could have your egg carried in someone else. You can have someone else's egg carried in you. You can have very specific sperm chosen. I'm sure there's other permutations, but that's what I could come up with off the top of my head. Anything you want to add to that, Rhea?
Yeah, no, that's right. I mean, I have a lot of same-sex couples that I see that do reciprocal IVF. So that's something kind of that you were like alluding to, which is a patient will undergo the stimulation, the retrieval, and then that egg, will get fertilized potentially with some type of donor sperm. And then the embryo, instead of going back to the original person who did the stimulation, can get transferred to their partner who will then carry the pregnancy. So we do reciprocal IVF quite a bit. So yeah, I mean, there's there's lots of different ways that we help families build their families, which is incredible. And so, yeah, it's a beautiful thing. This technology can be used in so many different ways. And, as Raman's example with his platonic co-parenthood, it's exciting to see, how things develop.
Have you come across situations where parents are trying to select embryos for specific traits like blue eyes, green eyes, or are we not there yet?
That's a great question. So you're kind of talking about like the designer baby, like is that happening? The answer is not happening. It's not happening clinically. And there's a lot of questions, ethical questions around that, in general, testing for hair color, eye color, skin color, these are polygenic traits. So in general, they are difficult to test for. They're not a single gene that you can just say, let me test for that and see, if my embryo has this trait or not. Like they're polygenic traits. So that means they're inherited multifactorially. There's a lot that goes into them. And so it's really challenging to even do that. And then there's a whole ethical component, about gene gene editing, gene selecting, building a designer baby. It's not being done clinically, is what I can say at this time. Who knows what the future holds, but at this time, it's not being offered in that way.
Yeah, let me know when it is. That'll be.
So we're going to move on to the Is This Normal segment. And I think a lot of women or couples are out there wondering if they're the only people having trouble conceiving. And not just trouble conceiving, but sometimes people are going through more than one IVF cycle. And I mean, as you've explained, this is a lot of mental anguish and physical stress on the body. And so how do you counsel your patients, and how I'm sure it hurts you when you've been trying to help a family have a baby and it doesn't work out.
Yeah, it's these are tough conversations, to put it mildly. Every family is unique, and I think the most challenging patients are definitely the ones that are, older than 40 who are coming and trying to get pregnant and typically require more than one IVF cycle. And if I could count the number of times I say, if I only had a crystal ball, if I could only predict this out for you, how many cycles this would take. I think that is the most challenging part of what I do on a day-to-day basis, is having those difficult conversations and assessing how a patient feels about trying again if one cycle didn't work out. So it's such an individual, person to person conversation, how that unfolds. Some patients find peace with trying, and maybe are not the best candidates for IVF and may have, poor egg reserve and be in an older age where IVF outcomes are less favorable. But they have peace in having tried, and they can, lay that to rest. And others would like to continue trying. And so that's part of also the ethical concern of how many cycles is, worthwhile to continue trying, and how many, we want to respect patient autonomy, right? Of course. But we also want to be mindful of, the additive effects of maybe doing these cycles and the physical toll it can take on someone. So these are all things that, we talk about, and I try to explain to my patients and see, where they're at emotionally, physically, with doing these cycles, especially in that population, which is more sensitive.
And I imagine it's really hard on if it is a couple undergoing this, it's hard on the couple too, because they're both feeling sad about it not working out. There might be guilt on one person's part that
Totally.
I'm not the one. And also I find that a lot of people tend to undergo this struggle alone. They don't usually share with a lot of people that they're undergoing IVF, and then that just adds, I think. So I think you're probably dealing with a lot of emotions with the individuals and couples that you're working with.
Oh, totally. Yeah. I think if I always advise my patients, to lean on each, especially if they're in a couple, if they're not going at it alone. If they're going at it alone, I advise them to lean on family, friends, partnerships, anyone they have that's close. But especially in a couple, to lean on each other. Sometimes they seek counseling, outside, because it is a lot. It is a heavy toll that it can play mentally, physically on a couple that's on this path, for sure.
Yeah.
All right. Well, with that, you want to go on to stuff you didn't know?
These are some really fun facts, definitely stuff I didn't know. And Rhea, please chime in and elaborate here. So when Ashley was having the embryo put inside of her, she kept talking about going in for her implant. The embryo was implanted, putting the embryo in her body. And that, I think we just want to clarify that terminology, because that's not what's actually necessarily happening. That's what we want to happen, right? What we're actually doing is transferring the embryo. Can you tell us exactly what's happening and then what we want to happen?
Yeah. No, totally. So it is called an embryo transfer. We hope that it'll implant. So we basically set up a patient for the embryo transfer. They come in, and then we gently place a small catheter with a loaded embryo, and we guide it, into the uterus under ultrasound guidance. And we release the embryo with good hopes and good thoughts, and we hope that it will stick, that it will implant, right? So we, typically test for that. So what will happen if it does successfully implant is around day 9, day 10 is when we start to see positive HCG results. We start to get blood work drawn, and we get to see the direct result of that, which is that the embryo now is secreting that hormone, the pregnancy hormone, the HCG hormone. So yes, we hope it implants, but it's called a transfer. Yes.
Yes. Okay. And then another thing I've heard is that the intended mom needs to have a very full bladder on the day of the transfer. Can you explain that?
Yeah, it's all down to anatomy. So your bladder and your uterus sit right next to each other. So your uterus, if you've heard of the terms, that it could be anteverted, where it's kind of propped up against your pelvic bone. It could be retroverted, where it's kind of hanging down below your pelvic bone, and all different. And it can also be midline. There's all different positions of the. There's all different positions of the uterus. So the full bladder, the goal of the full bladder is to really help it keep the uterus at a position that's not too angled. So sometimes actually we have them be really full. Sometimes we have them be a little emptier. Every patient's a little bit different. Maybe in your co-parent's perspective, she needed a really full bladder. That's probably the most common, that we do. And it helps us guide the actual catheter in smoothly without having to go through any twists and turns of the cervix and the uterine angle. So that's the purpose, is to keep that streamlined guidance of the catheter so we can have an easy transfer.
And I hear that almost every retrieval patient asks the same question when they wake up.
Of course. And that's what I'm ready to tell them as soon as they wake up, because I know they're looking at me for that, reassurance, hopefully, that I can give them, that good news.
Yeah, no, that's great. And then I think another something I didn't know was that the follicles that you retrieve don't always have eggs.
Back again. Yes. So while we typically will see a follicle, well, typically we'll see an egg in each and every follicle. There are some empty follicles. That is true. So, we aim to retrieve all the eggs that we can from the follicles, but there are occasions where a follicle will be empty. That's not explained.
Rhea, would you like to give us a closing for today? Something for people to walk away with?
Yeah, so IVF, in vitro fertilization, is a beautiful technology that exists to elegantly help patients have families, to build families. That's the goal of IVF. And so I hope this segment was inspirational and helpful for patients who are navigating what IVF is, what it entails. But it does give hope, and it does give options to so many patients working to build their families.
Rhea, thank you so much for being here today, Dr. Rhea. I really appreciate your expertise and your time with your newborn baby. And we learned so much, and we have more questions. So we really hope you'll be back.
Thank you so much, guys. It was such a pleasure being with you guys today. I really appreciate it. Thank you.
You were fantastic. So definitely please come back.
A lot of people go through fertility treatment completely alone. No one to ask questions, no one to explain what's going to happen at each stage. We hope today changed that a little. If you or someone you know are going through IVF, please share, rate, and review wherever you listen. That really helps Raman and me reach as many people as we can in our mission to help all parents and intended parents feel a little less unplanned.